Cardiovascular disease versus chronic kidney disease, a comparative study, using VMT and TDA models of 4 common stressors, number 1419, VMT sharp 743, TDA sharp 026, November 4, 2025, Gerald C. EclaireMD Foundation. Category, Comparative Pathophysiology. Preface. During my long battle with chronic diseases, 2 major complications shaped my medical journey. 5 episodes of cardiovascular disease, CVD, between 1994 and 2004, and chronic kidney disease, CKD, between 2010 and 2012. Both resulted from my obesity and diabetes and nearly ended my life. Yet both later became the focus of my scientific studies through the GH method, including Viscoplastic Medicine Theory, VMT, and Topological Data Analysis, TDA, frameworks. Although the heart and kidneys are separate organs, their failures share similar stress origins. A combination of vascular pressure overload and metabolic imbalance. In this paper, I compare my longitudinal CVD study, number 1417, and CKD study, number 1418, to identify the key similarities and differences in stress-strain dynamics, energy distribution, and geometric stability across these 2 life-threatening conditions. Shared framework and variables. Both studies use the same 4 normalized stress inputs for consistency. Pulse pressure, PP, reflects arterial stiffness and pulsatile load, directly affecting the heart, kidneys, and brain. Mean arterial pressure, MAP, represents perfusion, pressure and systemic circulation, responsible for delivering oxygen and nutrients to all organs. Fasting plasma glucose, FPG, indicates metabolic toxicity, resulting from insulin inefficiency and glucose dysregulation. Visceral fat percentage, VF%, measures chronic inflammation and insulin resistance, closely linked to overweight and obesity. In both organ systems, these 4 inputs represent the dual stress domains, vascular, PP plus MAP, and metabolic, FPG plus VF%. For a 79-year-old male with controlled diabetes and normalized hemodynamics over 15 years, these healthy parameters form a stable reference baseline. PP is 40 mm of mercury, MAP is 80 mm of mercury, FPG is 110 mg per deciliter, VF% is 13%. Both VMT and TDA models were applied to analyze stress-strain behavior over the 12-year period, from 2014 to 2025, during which both my heart and kidneys remained stable. Key similarities between CVD and CKD. 1. Energy and geometry alignment. In both diseases, the viscoplastic energy model, VMT, and the topological geometric model, TDA, produced consistent outcomes. Energy saturation in VMT matched geometric contraction in TDA, confirming that physics and topology describe the same biological reality from 2 perspectives. 2. Equilibrium achieved around 2020. Both organ systems reached their turning point near 2020. Before that year, VMT energy accumulated rapidly afterward. The systems entered equilibrium, with minimal further deformation. The TDA radius curve in both studies contracted sharply before 2020, and stayed compact through 2025. 3. Balanced stress domains. The energy contribution ratios were strikingly symmetrical. CVD, pages 26%, MAP 26%, FPG 25%, VF% 22%. CKD, pages 24%, MAP 24%, FPG 26%, VF% 26%. Vascular and metabolic domains were almost evenly split, around 5050. This symmetry shows that the pathogenesis of both diseases depends equally on blood pressure control and metabolic balance. 4. Topological contraction patterns. Both TDA diagrams show that the 2D and 3D point clusters were large and scattered during from 2014 to 2018, but contracted into compact, stable shapes by 2025. This geometric shrinkage corresponds to improved systemic coherence and reduced internal variance. 5. Reversibility through lifestyle control. Both conditions demonstrated partial functional reversibility of kidneys and heart through lifestyle discipline, diet, walking, hydration, sleep, and emotional stress control. I prevented further deterioration and achieved functional recovery. This finding challenges the belief that CVD and CKD are strictly irreversible diseases. Key differences between CVD and CKD. 1. Timing and severity. My CVD crisis occurred earlier, 1994, age 47, 2004, age 57, and involved 5 heart attacks. Acute and life-threatening events caused by hemodynamic instability. CKD developed later, 2010, age 63, 2012, age 65, as a slower metabolic and microvascular failure. Thus, CVD represents acute mechanical breakdown. while CKD reflects chronic structural degeneration. 2. Dominant stress type. In CVD, vascular stress slightly dominates, pp map 52%, confirming that pressure overload and arterial stiffness drive cardiac events. In CKD, metabolic stress slightly dominates, FPG-VF 52%, showing that glucose toxicity and adiposity play greater roles in renal damage. 3. Reversibility speed. The cardiovascular system reached equilibrium earlier, from 2019 to 2020, due to faster adaptive remodeling of large vessels. In contrast, kidney recovery lagged by several years, because microvascular and nephron structures regenerate slowly. 4. Functional sensitivity. CVD strain responds more to short-term pressure fluctuations, pp. map, while CKD strain integrates long-term cumulative toxicity, FPG, VF%. This difference in sensitivity reflects each organ's unique structure. The heart as a dynamic pump, the kidney as a filtration system. 5. Outcome patterns. CVD, residual vascular stiffness remains, but is well controlled below 50% strain since 2014. CKD, risk dropped from 71% in 2014 to about 60% in 2024, corresponding to full remission of symptoms. Unified interpretation. Both models describe the same biological law. The human body absorbs and dissipates internal energy until it reaches a viscoplastic equilibrium. When cumulative stress exceeds the yield limit, irreversible damage occurs, such as a heart attack or nephron loss. However, once stress is effectively controlled, the system stabilizes into a low entropy, steady state topology. During this process, partial, functional reversibility can be observed and confirmed. From an engineering perspective, both the cardiovascular and renal systems have transitioned from energy accumulation to energy dissipation modes. From a geometric perspective, both evolved from scattered, chaotic topologies to compact, organized manifolds. This convergence between physics engineering and mathematics geometry, and between two major mortality diseases, CVD-CKD, demonstrates that human chronic diseases follow universal nonlinear laws of dynamic equilibrium. Conclusion. Despite affecting different organs, CVD and CKD share nearly identical mathematical and geometric behaviors. Both began as high-energy, unstable systems, and evolved toward equilibrium through disciplined self-management. The heart reached balance earlier, the kidneys later, but both recovered. My CVD risk has remained below 50% since 2014, while my CKD risk declined from over 100% in 2010 to about 60% by 2024. For patients, this comparison offers hope. CVD and CKD are not final endpoints, but dynamic systems capable of stabilization and partial reversal. When stress energy is reduced and equilibrium restored, the body's natural resilience prevails. Disclaimer: I write this paper not for fame, but to share what I have learned so others can understand their health, prevent disease, and live longer, healthier lives. This content is for educational reference only, and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be altered, edited, or republished as your own. All intellectual property rights and copyrights belong to the author. Gerald C.